Thank you. So before we go on to the different field effects, let us understand a few terminologies like this. So firstly, when we draw the visual fields, we'll draw as what the patient sees. So the right eye is drawn on the right side and the left eye would be drawn on the left side. And in this particular case, we see for the right eye, the left part of the visual field is affected. And same for the left eye also, the left part of the visual field is affected. So in both eyes, the same side is affected. So therefore, this would be a homonymous hemianopia. And since it's on the left side, it would be left homonymous hemianopia. And the opposite would be the right homonymous hemianopia, where for the right eye, right side of the visual field will be affected. And for the left side, again, right side of the visual field would be affected. And the opposite would be the heteronymous hemianopias, where for the right eye, we see the right side is affected, and for the left eye, we see the left side is affected. When we want to talk in terms of nasal or temporal, we see both sides has got a temporal visual field effect. So this would be a bitemporal hemianopia, and it's a type of heteronymous field effects. And the opposite here again would be the binasal hemianopia, where for the right eye, the left side is affected, and for the left eye, right side is affected. So this would be the visual pathway and the various field effects that we have. So any visual field, any problem which is affecting beyond the chiasma will cause a homonymous field effect. And those which are anterior to the chiasma will cause a heteronymous field effect. So now at this next we will talk about the complete or incomplete. So complete means the entire side gets affected. And whereas in incomplete, only a part of the visual field is still persistent. So this has not come to the vertical meridian on the inferior aspect. So this would be an incomplete hemianopia. And what is congruous or incongruous? Congruous means they are symmetrical. So here we can see it is sort of a right superior quadrantopia, whereas an incongruous means there is asymmetry between the two eyes. So at this juncture, we'll also understand a few other concepts. Mainly, the image which falls on the retina is inverted, both horizontally and vertically. So we see the tower is falling upside down. So whatever is there superiorly will fall at the inferior part of the retina, and whatever is there inferiorly in the visual field will fall on the superior aspect of the retina. And same holds good for nasal and temporal as well. So parts on the nasal visual field will fall on the temporal retina, and parts which are there on the temporal visual field will fall on the nasal retina. And what are corresponding points? Those are points on the retina which has got the same visual direction. So say we are focusing at a point, a green square in space. So since we are looking at that particular object, that will pass on the fovea of both the eyes. So the fovea of both eyes are called corresponding points. Let us say, for example, we have another point besides the point of fixation. So now we connect it to the nodal point and extend it into the retina. It will fall at a point which is nasal to the fovea. And when we do the same for the other eye, we'll see that it is going to fall at a point which is temporal to the fovea on the right eye. So these 2 points, see nasal to the fovea on the left eye and temporal to the fovea on the right eye, they are also called corresponding points. Now let us take, before that, let us understand the visual field extent. So superiorly, the visual field extends for about 60 degrees. Inferiorly, it's around 75 degrees. Nasally, it's 60. And temporally, we have a large visual field of around 100 degrees. So let us take a point. Before that, what is the extent of the retina? The retina extends, the location of the retina is around 6 millimeters from the nasal limbus, whereas it's 7 millimeters from the temporal limbus. That is, the retina is more anterior on the nasal side than the temporal side. Let us take a point which is there in the extreme temporal visual field. Now, this point will fall on the extreme nasal retina of the right eye, whereas when it falls on the left eye, it is going to fall anterior to the retina. So that part would not be perceived. So any point which is on the extreme temporal field will be sort of uniocular. It will fall only on the right eye. And further, the nose will also block any light which is coming from the extreme temporal side. So if there is a defect which affects this portion of the retina, what we would get is a visual field defect in the extreme temporal periphery. So now at this juncture, we'll move on to the arrangement of fibers, which is very important to understand the different field defects that happens in neuro-ophthalmology. So firstly, we have the papillomacular bundle and the macular fibers. The disc is located on the nasal side and the macula is located on the temporal side when we look at their orientation. So fibers which are originating from the macula pass directly into the optic disc. So it will pass to the temporal aspect of the optic disc here. So then the fibers which are there temporal to the macula, both above and below, will arch above the papillomacular and below the papillomacular bundle and reach the superior and inferior aspects of the optic disc. Now, this is very important that it's not temporal to the optic disc, but it's temporal to the macula. So these fibers, the axons of the ganglion cells which are there temporal to the macula, will go to the superior and inferior aspects of the optic disc. And those ganglion cells which are originating from the nasal aspect, anywhere nasal to the macula in the retina, will go into the nasal aspect of the optic disc. So the arrangement of fibers when we do a cut section of the optic nerve head, so we'll see like this. So this would be the cup. All the temporal fibers go to the temporal aspect of the optic nerve head. The arching fibers from the temporal side will go to the superior and inferior aspects. And all fibers which are there nasal to the macula will go to the nasal aspect. Now we also spoke about this uniocular field. For that, we'll understand this part. So that is the extreme nasal peripheral retina. Now, when we look at the retinal ganglion cell arrangement, those fibers which are there in the extreme periphery will take a long intraretinal course and go to the outermost part of the optic disc. That is, it is away from the cup. Whereas those ganglion cells which are originating close to the optic disc, like somewhere here, it will take a short intraretinal course and go towards the center of the cup. So we see that the nasal uniocular fibers, which are originating from the extreme peripheral nasal retina, will go to the will go to the outermost aspect of the optic disc on the nasal side. So that's why we have drawn these uniocular nasal fibers in the most medial portion of the optic disc. So this is with regards to the optic nerve head. Now what happens a bit posteriorly? So after the optic nerve, after the optic nerve head, we have the optic nerve until it reaches the chiasma. So here what happens is there is sliding of the upper temporal and the lower temporal fibers. So the macular fibers come to lie in the center, whereas the temporal fibers, upper temporal and lower temporal, will slide towards the temporal side. So this is the only change that is going to happen in the optic nerve compared to the optic nerve head. Now, what happens if there is a optic nerve lesion? So say, look at this point 2 here, where there is one optic nerve which is getting damaged. So this eye will have sort of total blindness if it's completely transected, whereas the other eye would be absolutely normal. So it need not affect all the portions of the optic nerve. It need not be a complete transection. So whichever fibers are getting affected, that particular visual field will be there. But the most important thing is the other eye would be totally normal in case of an anterior optic nerve lesion. So say if the lesion is close to the chiasma, we'll have something called the junctional scotoma of trachea. Now let us understand what that is. So we all know that the nasal fibers cross at the region of the optic chiasma. Now, but the crossing is not direct straight movement to the opposite side. So here we have the infranasal fibers and the supranasal fibers. Here we have the infratemporal and the supratemporal fibers. Now, instead of going straight like this to the opposite side, these infranasal fibers will go to the opposite optic nerve to a certain extent, and then go to the optic tract. Now this is called the antennæ of Willebrand. Now say we have got a posterior optic nerve lesion which is affecting this particular area. So these infranasal fibers from the opposite eye is also going to get affected. So what type of field defect would we get? So the same side optic nerve is cut. So it can have any type of field defect depending upon the axons which are getting damaged, or if it's completely transected, we'll have a total blindness of the left eye. And for the right eye, we have the infranasal fibers which are getting affected. Now, infranasal fibers correspond to what visual fields? It would be the supratemporal visual fields. So we have a supratemporal field defect in the right eye. Now, this is called the junctional scotoma of trachea, when the anterior knee of Willebrand is getting affected. Similarly, we also have a posterior Willebrand's knee, but that does not have much of a clinical significance because it is not going too much into the optic tract. The supranasal fibers goes like this. So this is with regards to the chiasmal lesion. Posterior optic nerve lesion. Now let us go to the chiasmal lesion. Now in chiasma, what are the fibers that are crossing? It is the nasal fibers that are going to cross at the level of chiasma. The nasal fibers from the right eye and the nasal fibers from the left eye, which corresponds to the temporal visual fields. So since in addition, there are also the macular fibers which are crossing. So we have a sort of vertical meridian gets respected there. So we have a bitemporal hemianopia. So here we can see the number 3 point is getting cut, which corresponds to the nasal retina of the left eye and also the nasal retina from the right eye, which corresponds to this bitemporal hemianopic field defect. But these field defects do not develop overnight. So optic chiasmal lesion is usually occurs due to compression, either due to a pituitary adenoma or a craniopharyngioma. Now, so here we see the pituitary here. So if the pituitary has to enlarge, it is going to compress the inferior part of the chiasma first, right? So let us look at this particular example now. So as the pituitary enlarges, firstly, the inferior portion gets compressed, and as it becomes bigger and bigger, the entire optic chiasma gets compressed. So at the last stage, we'll have a bitemporal hemianopia, but when it starts, it usually starts on the superior aspect because the inferior fibers are getting affected. As we saw, the visual field is opposite to what happens in the orientation is there in the retina. So initially it starts as a bitemporal superior quadrantopia, but as the tumor becomes bigger, it is going to cause a bitemporal hemianopia. The opposite happens in case of a craniopharyngioma, where it is going to compress the chiasma from above. So initially the compression would be on the superior fibers, which corresponds to the inferior visual fields. So it starts as a bitemporal inferior quadrantopia, but as it becomes bigger and bigger, it becomes a bitemporal hemianopia. Now, what else do we get in case of a chiasmal lesion? So we saw all the nasal fibers are crossing, and also the macular fibers, nasal part of the macular fibers also cross at the level of chiasma. Now, when you want to look at the same orientation in the optic nerve head, we see the macular fibers are going to the temporal aspect of the optic disc, and all the nasal fibers, that is nasal to the macula, which are crossing at the chiasma, will go to the nasal aspect of the optic disc. Now, when there is a chiasmal pathology, both these axons are going to get atrophied. Now, because of that, we'll have pallor on the temporal side and also on the nasal side. So this is called a bow tie optic atrophy. So here we can see superior and inferiorly, we don't have much of pallor, whereas nasally and temporally, we have significant pallor. So this happens in case of a chiasmal lesion. Now, going posteriorly from the chiasma, next we have the optic tract. So here, what is the difference is there is a slight inward twist of the nerve bundle. So whatever was there superiorly will become supromedially. So it goes on like this, and whatever was there inferiorly will become infralaterally. And also we have in the optic tract, we have the crossed fibers from the opposite side, nasal retina, and the uncrossed fibers from the same side, temporal retina. Now they both mingle with each other, so there is no distinguishing between upper nasal or upper temporal. We just say upper peripheral in case of optic tract. Now, what happens in lesions of the optic tract? So look at number 5 here. So here, sorry, yeah, here what happens is the same side temporal fibers are getting affected, which corresponds to the nasal visual field on the left eye. And the opposite side, nasal fibers are getting affected, which is corresponding to the temporal visual field on the right eye. So we'll have left-sided field defect in the left eye and right-sided field defect in the left eye and right-sided field defect in the right eye. So this would be a right homonymous hemianopia on the contralateral side because it's a left optic tract lesion. Okay. Next, going posteriorly, we'll go to the lateral geniculate body. Now this is quite interesting. So here we saw from the optic nerve to the chiasma, we saw there was an inward twist and this twisting continues. So in the lateral geniculate body, what happens is whatever was there on the superolateral aspect is going to become superior because of the inward twist. So the macular fibers come to lie superiorly in the lateral geniculate body, and the uniocular fibers, which were there inframedially, will come to lie inferiorly in the level of lateral geniculate body. So that's the only change that's happening. Apart from that, when we look at the cut section of the lateral geniculate body, they are arranged in various laminae. So 1 to 6. So the crossed fibers goes to lamina 1, 4, and 6, whereas the uncrossed fibers goes to lamina 2, 3, and 5. Now, say for example, we have a lesion in the lateral geniculate body. The entire lateral geniculate body is gone. We'll have a field effect similar to what we had in the optic tract. That is the contralateral homonymous hemianopia, because only those fibers are there on the left side now. Now, for example, let us consider a hypothetical scenario when only this part of the lateral geniculate body is getting affected. That is, only the lowermost part, lowermost fibers from the retina are getting affected. Now, what type of field effect we'll get? If the entire lateral geniculate body goes, we'll get a contralateral homonymous hemianopia. Whereas, if only the lowermost portion goes off, what we'll get would be a contralateral superior quadrantopia, because the upper fibers are spared, which corresponds to the lower part of the visual field. This part of the visual field will be spared if we have a lateral geniculate body lesion like this. Okay. We'll extrapolate this further. Let us consider a scenario when only this portion of the lateral geniculate body is getting affected. That is the outermost portion of the lateral geniculate body, which corresponds to the lowermost fibers. We'll get a field effect like this. Okay. So with this context, we'll understand the blood supply of the lateral geniculate body. So lateral geniculate body is supplied by two blood vessels, the anterocoroidal artery and the lateral choroidal artery. Now, anterocoroidal artery supplies the outermost aspect and the innermost aspect, and the lateral choroidal artery supplies the middle part of the lateral geniculate body. And these are the corresponding visual field representations of the particular portions. The color coding is self-explanatory. The red one is what we saw earlier. The outermost part of the lateral geniculate body correspond to the most superior part of the visual field. Now, say we have a anterior or lateral choroidal artery occlusion. So, what is the part which is getting affected? It is the central part of the lateral geniculate body which is going to get affected. Now, if this center part goes off, what we'll get is a field effect corresponding to this particular sector, green and yellow. So this is called a sectoronopia. So any lateral geniculate body, vascular lesion of the lateral geniculate body will cause a sectoronopia. It's a homonymous horizontal sectoronopia on the contralateral side. Say we have got a anterior choroidal artery block. So it is going to affect the outermost and innermost aspects of the lateral geniculate body. So we'll have field effects corresponding to this red and blue portions. So this would be a sector sparing homonymous hemianopia. So with this, we can identify which blood vessel is getting blocked in the lateral geniculate body. Okay, moving posteriorly, we have the optic radiation. Now, what happens in case of an optic radiation is, again, it separates into superior and inferior. So that is, so we have the lateral geniculate body here. Those fibers which are there on the lateral side will go inferiorly, and those fibers which are on the medial side will go superiorly. So these fibers on the lateral side will go anteriorly, around the anterior tip of the temporal horn of the lateral ventricle, through the temporal lobe, and then go to the visual cortex. Whereas those fibers which are there on the medial side of the lateral geniculate body will directly go through the parietal lobe and ultimately reach the occipital cortex. Now, what happens if there is a temporal lobe lesion? It's only the lower fibers which are getting affected. The upper fibers are spared. It is this one, similar to a lesion like this. So what we'll get would be a superior quadrantopia, contralateral superior quadrantopia. So this is in case of a temporal lobe lesion. Whereas in case of a parietal lobe lesion, it is the upper fibers which are getting affected. So it corresponds to this particular axons. So what happens is we'll get a pie in the floor. So this is called pie in the sky, and this would be called a pie in the floor, because it is the upper fibers which are getting affected, which corresponds to the lower part of the visual field. Now, if there is an entire area of the optic radiation goes off, we'll get both together. It would still be a contralateral homonymous hemianopia, because the rest of the portions goes through the opposite side. So this is with regards to optic radiation. And next, we'll move on to the visual cortex. Now, what is the arrangement of fibers in the visual cortex? Now, at the cortex, a large area is being represented by the macular fibers. Though macula is a very small portion of the retina, there is a wide representation at the occipital cortex. And this would be at the occipital tip, that is the most posterior portion of the brain. And a little anteriorly in the occipital cortex lies the upper peripheral and the lower peripheral fibers. And even more anteriorly, we have got the uniocular fibers, that is from the opposite side, opposite retina. Now, in case of a occipital lesion, what happens? So we'll have a contralateral homonymous hemianopia, but in addition, what we'll have would be a macular sparing. So up till optic radiation, from optic tract to optic radiation, if the entire part gets affected, it will cause a contralateral homonymous hemianopia. But when there is an occipital lesion, we'll have macular sparing. Now, why should we develop macular sparing? Various reasons have been given for this. One of the most common ones is the extensive macular representation at the cerebrum. We saw earlier the arrangement of fibers is such that the large part of the posterior portion of the occipital cortex is representing the macula. Now, lesion has to be so large to affect the macular fibers. So that is one. Secondly, the occipital cortex is all supplied by two blood vessels, the middle cerebral and the posterior cerebral arteries. Then there is also bilateral representation of the macula, and there is crossing of the macular fibers in the chiasma, and there are also other connections through the splenium of corpus callosum. And even if all things fail, there could be some shift in ocular fixation, like eccentric fixation developing, which helps in retaining some macular function. Now, finally, let us understand this temporal crescent. Now, let us take a lesion which is affecting the most anterior part of the occipital cortex. So it is these fibers which are getting affected, which is the uniocular fibers. Now, what happens? These are fibers which are coming from the opposite retina. So we'll get a field effect like this, because these fibers are suppose there is an object in the very extreme temporal visual field, this is going to fall on the nasal retina of the right eye and the temporal part of the left eye, but there are no photoreceptors there, so it is not perceived. And these fibers falling on the nasal retina is going to get crossed at the chiasma and goes through all the places and finally reach the occipital cortex, anterior tip of the occipital cortex. Now, when there is a lesion here, we'll get a temporal, very extreme temporal visual field effect on the contralateral side. And this is called the temporal crescent or half moon syndrome. And this is one of the examples of a uniocular field effect in a retrochiasmal lesion. But this is quite rare. Now, these are the various defects that we saw in the visual pathway. There are some other neurological field defects which are quite common. Let us see a few examples. So this is a fundus image of a patient who is an uncontrolled diabetic and a chronic smoker. He presented with sudden painless loss of vision. And when we look at the fundus closely, we see there is disc edema. And specifically, we see some amount of pallor in the superior part of the optic disc. So it's a pallid disc edema. And when we do the visual fields, we get an inferior field effect, and this is called an altitudinal field effect because it's like respecting the horizontal meridian, and the central fibers are also getting affected, and therefore it's not an arcuate field effect. So what would be the diagnosis here? It's a non-arteritic anti-ischemic optic neuropathy. Then let us look at another example, a 30-year-old female who presented with sudden painful defective vision for 4 days and fundus showed a disc edema. When we looked at the germ screen, we see there is a central scotoma. I mean, there's a scotoma involving both the center, that is the macula, and also the blind spot. So it's involving both central and the cecum, which is the blind spot. It's a centrocecal scotoma, which is common in optic neuritis. Though in optic neuritis, there could be any type of field effect, centrocecal scotoma is quite common. And this is a patient with papilledema, and we see the field effect shows there is an enlarged blind spot, which happens due to sliding of the photoreceptors. But enlarged blind spot is not specific for papilledema. It could happen in various other reasons like a myopic fundus, or when there is a large peripapillary atrophy like this. It could also be a feature of optic neuritis, or it could be early stage of glaucoma as well. So these are the other common field effects that can happen due to specific fundus causes. So it would be the end of presentation. I am happy to take any questions if you have.